are going to launch a new version of our mobile application. And whenever we do clinical practice, we are often challenged with scenarios where we don't remember everything, we don't understand the approach, and we don't understand the figures. We want to use some calculator, and it's very difficult to do it on a day-to-day basis. Now, I always thought that when you are managing a case, like a challenging case comes to you, let's say of a persistent hyperinsulinism, the conventional approach is that you go back to the books, start reading from there, try to get back, and then decide how to manage. The problem of this approach is that most of the time you'll start off with pathophysiology, then you will go on to what are the causes, then you will go to evaluation. So by the time you reach to the management, it becomes difficult. So what we have been trying to do and what we have been thinking for over a decade is to bring those algorithms that have been developed into real practice, which make it very easy and to do it on a point of care fashion. These are relevant predominantly for people who have less exposure in pediatric endocrinology, but also helpful for everybody. So if you're using it and you're sure that this is the way it should go in a precise manner, the applications will help out. So we started around 5 years ago, and today we're going to start off with many new formats of these interpreters, which will allow us immediate evaluation and management on that perspective. So over the next 2 hours or so, we are going to really highlight how these solutions can help out in terms of our day-to-day pediatric endocrine care. Now, why we started thinking of developing these tools was this case, whom I managed when I came back immediately, maybe 15, 16 years ago, was this 7-year-old boy with short stature who came to us at a time when nothing could be done, in that the bones were fused. Now, this is not unusual. Still, 10 to 15% children come to us at a very late stage. What was unfortunate in this case was that he had all the features of celiac disease. He was TTG positive, but unfortunately, because of the severe anemia he had, that was maybe around that 5 to 6 years ago, he was evaluated by a pediatrician who advised blood transfusion, which culminated into HIV/AIDS. So a reversible thing, a very simple thing like celiac disease turned out to be in a very adverse scenario. And that made us think what could have gone wrong and how could we have improved in that regards. So the most important thing in terms of the improvement of care of any particular individual with a health disorder is awareness. If the patient is aware at the right time when to go to the doctor, if the doctor is aware what things to order, how to evaluate, we can prevent most of the things. Accessibility to specialists is number two. Affordability is last. So often people think of pediatric endocrinology that you need very expensive investigations in a very complicated scenario, which is not true. If you do it at the right time, you can identify in that regards. Now, how do we really have a true evidence-based clinical practice? For that, there are multiple things that we need to implement. Of course, there are a large amount of books which are available. You have to put all that knowledge back into clinical practice. This involves ordering rational tests, especially in resource-poor settings where you can't just order every test all the time. You have to use that in terms of algorithms. You have to understand about the various drugs, the interaction, how to use, what dose to use, and then finally you have to take everything up to make that. So the process of a rational management of a child with endocrine disorders, of any child, requires a comprehensive combination of diagnostic, therapeutics, approach, management. All this perspective is important. So we tried to build up resources which will help us in terms of overall improvement of pediatric endocrine care initially in the country and then beyond that. So we started with workshops. So we have conducted over 200 workshops across the country. But that itself is a very tedious process, and the retention of people is not a long time. So they will forget. Maybe once you do a workshop, 1 week later, everything is gone because they're not implementing in the clinical practice. We started with practical courses. So 15 courses have been done in the country, but they are extremely resource intensive. You would need a lot of time, energy, money, everything. So it's not easily feasible. We started with our YouTube program, which provides a lot of free channels. So this is also there. We started an on-site fellowship. So till now, we have 14 fellows who have joined. So this is something. But then again, the reach is limited. To take it forward, we started with our MedEClasses, which was our online portal, which takes it beyond the routine classroom to beyond so that people can use that knowledge and understand in a systematic fashion, brought up the textbooks. But then at the end of it, what we realize is that unless and until we have something in the hands of a physician at the time of management, they would not be able to take the implement all this knowledge, because knowledge is there. Unless you see it day in and out, then it's in your reflex. Otherwise, you will forget. So then we thought 5 years ago to develop a mobile application, which at that time was a unique way of managing cases, and still now it is one of the very rare ones in that perspective. So as I said, we have done a lot of pediatrician initiatives across India and abroad, including a lot of workshops, practical courses, advanced courses in that perspective. Our e-learning portal has got huge number of videos and a lot of watch time. We have organized learning, which is a validated program at learning.growsociety.in, which offers courses for pediatric endocrinology to various aspects, starting from the fellowship program to small fragmented courses in that regards. And these have been accessed from people across the globe, which has culminated in that. We have got 3 publications, both basic, advanced, and protocols, which form the basis of many of these applications. So all these algorithms that we use now are largely based upon many guidelines plus clinical experience, and many of these are already published in these books. So we have used that to translate these books right away for clinical management. So the MedEClasses Endocrinology was the app which was basically released around 5 years ago. It is the most downloaded pediatric endocrinology app, or an endocrinology app, so to speak, with 10,000 installs. There are multiple places where it has been presented, multiple awards have been given. There are publications also which have come out from there. Now, the crux of this app is to try to translate what knowledge is in terms of clinical practice. So the most important ones which started off were approach pathways. Now, how these approach pathways were working were like these flowcharts. So there will be questions which people will answer, and based upon those question answer, we would be able to achieve the diagnosis in that perspective. And this is how you will read. So based upon your results, the next question will come up, and then subsequent to that, a final diagnosis will come up. So this was a stepwise approach. It simplified the algorithm. Now, if you have, let's say, algorithm pasted in front of you also, it may be more difficult, but if you get precise answers, it made it much easier in that regard. So there are covering entire parts of pediatric endocrinology in the approach pathway. There are management pathways similarly, because many of these scenarios, like if you think of increased insulin effect, how do you decide which workup to do, what to do? So we developed these management pathways. This allows implementation of algorithmic approaches and management on a clinical basis. So it gives you a personalized guidance. Now, the problem with these pathways is, which I don't think it's a problem, it's part of their way they have been developed, is that it will take a bit more time and you will have to put inputs every time. This is an advantage also, because then you can get a much more detailed picture of the clinical scenario. But often in this day and age, we want instantaneous results, that we want immediately that you input the data and you get the output. So for that, what we tried to develop was interpreters. And one of these interpreters is like thyroid interpreter, which Dr. Vibha will talk a bit more, in which what you do is that you just enter your analysis, and based upon that, you will get the diagnosis as to what you're dealing with. We have now largely taken forward a number of interpreters, and this time which we are going to launch is interpreters which are holistic approaches for complete electrolyte disorders in a single interpreter, hypoglycemia, calcium, and these interpreters have become, they are instantaneously more helpful because they give immediate results. But we need to remember is that because they are based upon one-time input, they may not be as encompassing as compared to a approach pathway. So often if somebody uses that, like here what it says, follow approach pathway as well. So this is for the initial guidance, and then you can go ahead and use the approach pathway from that perspective. Now, of course, when you say that you do a particular test, let's say a AMH test, you need to understand when to do the test, how to do the test. So you don't want to go back to the book and open it up. We have a full diagnostic section which provides what is the timing, what is the sample type, what is the reference range, and everything is available within the app. So within a single app, you've got all the information. Similarly, if you want to prescribe a drug, there is a therapeutic section which really provides the detailed information. So all the drugs which are used in pediatric endocrinology are there, and we give all the adverse effects, interaction, and all those parts in that regards. Many times in pediatric endocrinology and other aspects, you want instantaneous calculation of things. And this is something which we have provided. And this is not only simple calculator, it is also helping us in scoring system. So like external masculinization score, often people will forget. Those who are not using it regularly won't remember. So here you will get what exactly you have to input and you will get the result. Similarly, bone age, this was an Achilles heel for pediatricians. So this was a major development which we did in terms of developing a bone age tool which uses only 5 sites to provide an accurate estimation of bone age, which can be done rapidly even via a non-expert. So this is something which has been used now across the globe. This has been published and validated, and we are going to make it even more simpler, hopefully soon. And things like Ferriman-Gallwey score, which may not be possible for the patient to examine right in the clinic, we can ask the patient to self-rate and they will give you a picture. So this is going to help you provide an objective estimate of clinical parameters. Now, many people say, okay, we now have a pathway, we now have interpreter, but we want to learn a lot. Now, what we have done is that entire knowledge bank, which is there in our website, is provided here as well. So if you want to read a particular thing without the figures, otherwise the load will become too big. The app will become a lot of GBs there. You have got all the textual information you can read about any particular condition. So entire knowledge pathway is there. And you can also test your knowledge using the mobile pathways in which questions are there, which scenarios can be used. So what we have tried to do is to bridge all the things, including diagnostics, therapeutics, approach, analytics, to get the clinical management based upon the latest state-of-the-art guidelines from that perspective. And this is something which we wanted to do. So a lot of awards have been given. So in 2019, we had the presentation as far as the bone age interpreter is concerned. Dr. Riddhi had presented that and won 2 awards, one from the IAP Research Conference and the Indian Society of Pediatric Endocrinology in 2019. Dr. Sayan won the award and the West Bengal IAP in 2022 regarding puberty interpreter. Then we had a good presentation on bone age in the novel tool used by Dr. Naveen at the Asia Pacific Pediatric Endocrine Society conference in Seoul. Dr. Vibha has been presenting many of these ones, including in the American Thyroid Association, including the thyroid interpreter. Then we had Dr. Alapan, who presented the diabetes interpreter at the Asia Pacific conference. Dr. Dhwani, who won the DSD interpreter. So a lot of publications have come out from there, including the growth chart, the DKA management, and the bone age assessment, and many more are on the way. So what we're going to do today is to try to cover a wide variety of pediatric endocrinology and how our tools can help us. We need to understand that there is a spectrum of disorders which are there. The most important thing to look at in the setting of hypoglycemia is ketone level. Everybody who is hypoglycemic should be ketotic. If the ketone is not there, then we're dealing with hyperinsulinism, fatty acid oxidation defect, or galactosemia in that regards. Second is lactic acidosis. If your lactate is present, you are specifically looking at glycogen storage disease or a gluconeogenic defect. If there is acidosis, then you add organic acidemia in the differential, and insulin should be undetectable in anybody who has got a scenario of hypoglycemia. And then glucagon test. So mostly what we're looking at is the ketone, lactate, and insulin. And when we discuss about the interpreter with Alapan, we'll talk about only these 3 parameters. So this is what you need to really understand. What we also need to understand is what is the physiological response to hypoglycemia. If your sugar is below 50, you should have no insulin. You should also have a ketone which is more than 2. You should have a cortisol more than 550 and a growth hormone level more than 10. So this is a normal response. So when we talk about critical samples, you have to take these critical samples to interpret and get the result, and lactate should be low, and any detectable insulin becomes hyperinsulinism. Non-ketotic becomes hyperinsulinism, fatty acid oxidation defect, and galactosemia, and high lactate suggests GSD1 and gluconeogenic defect, while cortisol deficiency will suggest MPHD. Other important thing to remember is that there is a physiological dip in glucose level in the first 24 to 48 hours. After 48 hours, a neonate will behave as if they have a normal adult homeostasis. So within the 48 hours, you can have a lower sugar levels. So we need to talk about operational thresholds, less than 25 milligram per DL in the first 4 hours, less than 35 in the 4 to 24 hour, then 50, and then 60. So we need to understand that a lot of unnecessary workup is done when we are not following these cutoffs and thresholds in that regard. So just to summarize the approach, if ketone is low or absent, look at reducing substance. Positive, galactosemia or fructose intolerance. Negative, look at insulin. Undetectable insulin, fatty acid oxidation defect, detectable hyperinsulinism. If somebody is ketotic and lactate is high, we have GSD1 or gluconeogenic defect. Normal, look at organomegaly to identify GSD3 and 6, and then look for growth hormone deficiency or go to accelerated starvation. So essentially, this is what we have put in our hypoglycemia interpreter, which is part of this next generation app. And if you have hyperinsulinism, further, we have also included this. If the hyperinsulinism is there, first of all, give dextrose and diazoxide. If there is no diazoxide response, then you start thinking of refractory causes. Consider a genetic study for a potassium ATP channel defect. If there is a recessive defect, it's a diffuse disease, surgery is required. If it's a paternal defect or Beckwith-Wiedemann syndrome, then you can do a fluorodopa PET. So these two algorithms is what we have interpreted there, and we'll start off with the cases.
So 3-hour-old girl child presented with a blood sugar level of 35 milligram of BN.
So what do you think? You have been referred.
So if we see the cutoffs, so in the first 4 hours, we should have blood sugar level less than 25. So we'll not consider it even a case of a.
So you will look for symptoms and you will say, okay, continue, encourage feeding and other things. Then let's see what the app does. So the app has got neonatal arm and the post-neonatal arm. And so basically, if you look into this, if you go into the neonatal and you put the data, you have to tell how many hours is the child, and then you enter what is the glucose level. You're saying 35, and it will say normal, no need for workup. It doesn't mean that you don't reassure in terms of feeding, another perspective. Now, second scenario, now we come back, 28 hours, blood sugar is 44. Do you think this is significant?
Yes, this time I think the blood sugar is a bit lower from the threshold at least, and we should look for the symptoms, whether it is present or not in this child.
Symptoms for hypoglycemia will decide. We'll like to work up.
I don't want to work up in this child. If you want to seek consideration of feeding trial initially, if it is not improving by 48 hours or then we can think.
48 hours is the holy grail as far as when you want to start workup, because otherwise you will start workup in everybody. So what we are seeing here, glucose is 44. It's saying you have symptoms. Your symptoms are there. So then, because of symptomatic, it's saying that you can consider a dextrose bolus and start glucose infusion. So all the guideline has come up out here in the easy perspective. Now moving to more complicated cases, 3-week-old boy with seizures and hypoglycemia. What would you like to look at here clinically?
Clinically, I would like to look the birth weight of this child.
At 3 weeks?
Unlikely, but
so what else?
We can look for the maternal history, whether it is present or not. And we should look for any stress full condition in the present in the child or not.
So he's come to you, he was fine, he was discharged. He comes back at 3 weeks with hypoglycemia. So you have to think of some other things. So these are more for transient causes you're talking about. We should look for the liver.
Okay, hepatomegaly also.
You should look for cataract. You should look for all the other features that we talked about in that perspective. So now, of course, ketone becomes important. Ketone is positive. And sodium is 128, potassium is 3.6. What do you think is happening here?
So this is a case of ketotic hypoglycemia. The ketone is positive, but the sodium is on the bit lower side. So we should look for the other pituitary hormones to see any pointers. The micropenis is there.
Micropenis also. So this is what the message is. So this is clearly a ketotic hypoglycemia. So if you put the age and you put the glucose level, what you're finding here is the glucose level here is low, of course, for the threshold. So 28 is low. We are looking at ketone. So it gives an option also if you don't have a blood ketone to put a urine ketone as well. And blood ketone is positive, then of course you will go do the cortisol. And 125 was reported as normal. Do you agree with that?
In the scenario, we should look for a contextual assessment. So in a case of 128 and a blood sugar of 28, cortisol should be much higher, like more than 500 or more than 550 in this case. So we'll take this as
so with a micropenis, with the low cortisol, hypoglycemia, ketotic, and hyponatremia, the diagnosis will be most likely a multiple pituitary hormone deficiency. Now, another 3-week-old boy with failure to thrive, again hypoglycemia, but not requiring too much glucose. There is a hepatomegaly. What do you think of?
Here also, there could be a possibility of galactosemia, infection, any kind of, or hyperinsulinism also can cause this kind of hepatomegaly in the
So you
children.
will like to know about the
ketone level. I would like to see the
ketone is negative.
So
0.4.
we would like to see for the urine reducing substance before leveling someone as
So you can look at insulin or reducing substance, and that was suggestive of a galactosemia. So this is going to help you out in terms of diagnosis. A very common scenario: 14-year-old boy with birth asphyxia in the ICU. There is hypoglycemia. GIR is 14 milligram per kg per minute. This child requires evaluation.
Yes, because he is 14-day-old in birth.
And now the ketone is negative and insulin is 4.2.
So there are some pointers like GIR is very high in this child. There is birth asphyxia. The child was admitted in ICU and it has presented in around 14 days. So if ketone is negative, we should consider for the reducing substance. If it is negative, we should see for the insulin level. Insulin level here is detectable. So any detectable insulin level in setting of a hypoglycemia should consideration of a hyperinsulinism. And in the setting of birth asphyxia, we should always look for whether it is a case of prolonged hyperinsulinism.
So birth asphyxia with SGA, think of prolonged hyperinsulinism, and we can give a trial of diazoxide as we discussed. 3-day-old boy with severe hypoglycemia, weight is 4,600 grams. GIR is very high. So what do you think is happening here?
Again, this is a large for gestational age child having hypoglycemia in a 3-day-old boy. GIR is too high for this child. So you'll consider a hyperinsulinism state in this child also.
Ketone was 0.8, insulin is detectable. Then of course we go forward in terms of hyperinsulinism algorithm.
Yes.
So this is a LGA. So LGA would basically mean that it's unlikely to respond to diazoxide. And as we discussed in that algorithm, you should consider a genetic study for child and parents. That will tell you whether it's a focal or a diffuse form. And then you can plan therapy from that perspective. Now we go into older child. 1-year-old boy with seizures with hypoglycemia. Ketone is negative.
So we should always see for the insulin level in this case also. Insulin is undetectable. So we should see for and here the reducing substance is also positive. So
yeah, so it will go in favor of a fructose intolerance in that regard.
6-month-old boy presented with lethargy and blood sugar level is 36, a low blood sugar level, and ketone is positive. Lactate is higher on the higher side.
So what are you thinking of?
So it could be a glycogen storage disease in this 6-month-old.
GSD1 or fructose 1,6 bisphosphatase deficiency. You can think of a glucagon test and hepatomegaly. So if you just use these basic clinical parameters, you can make the diagnosis. Very common case: 1-year-old girl not waking up in the morning. Blood sugar is only 24.
So hypoglycemia is definitely there. We should look for the ketone level. I think ketone is positive in this child, and lactate is not detectable. There is no hepatomegaly. So we'll look for the pituitary hormone deficiencies, whether it is present or not, and it is clearly showing there is no deficiency. It could be a case of accelerated starvation.
So again, the message is, if you look at very simple parameters, the age, the level of sugars, what is the glucose infusion requirement, ketones are there or not, lactate, you will get the diagnosis. Now, more of people think about that if you have technology, it is going to replace the physician. It's not going to. Technology is there to assist the physician. And if we do not move with the technology, then we may be left behind. So what our aim is, definitely not to replace any clinician. It's just to support, aid, guide. Sometimes you're not sure about what the guidelines would suggest, what level is appropriate, how to do those calculations. The app is meant to help out. And it also specifically tells you where you need to seek a specialist opinion as well. So this is mainly to assist people at all levels. And our studies, if you look at the interpreters for DSD, for diabetes, it may also be helpful not only for the training pediatricians or the pediatricians, but even for endocrinologists and pediatric endocrinologists. So just to ensure that you have a continuous growth, you can just have a look as to what it is suggesting. And then final diagnosis treatment will depend upon, of course, the overall clinical scenario. So we encourage all of you to go and have a look at our MedEClasses endocrinology app. It's available both on Android and iOS store. In the first 7 days, it's free for use for everybody. So you can have a look at it. And then it's available for subscription at a nominal fees in terms of the clinical perspective.